right, thanks for the opportunity to present at the national meeting today. So I'm one of Radiation Oncology Clinical Research Fellow at Austin. I'm going to talk about evaluation of the radiation oncology choosing wisely recommendation, which is something really more tailored to radiation oncology doctors. I think it was mentioned earlier that there's not much of radiation oncology involvement in most of the things, but we are generally a kind of low-profile specialty. But this is mainly just to highlight that, not really to go through the exact radiotherapy side of things, but to highlight that there are a lot of administrative data set out there that can be used to evaluate the choosing wisely recommendation. So these are the 5 radiation oncology specific choosing wisely recommendation that was released in 2016, and I'll go through more in detail some of those. But it's really important to bear in mind when putting forward a choosing wisely recommendation that it really needs to be supported by level 1 evidence. We need to have some evidence that there's actually some deviation from wise practice, whether it's a underuse of evidence-based practice or overuse of non-evidence-based practice. And it will be useful if the recommendation itself is measurable or evaluable, but it's not necessarily a must. So of the 5 choosing wise recommendation, only 3 are actually evaluable using the Victorian Radiotherapy minimum data set, the VRMDS. So VRMDS is an administrative data set maintained by the Victorian Department of Health and Human Services in collaboration with all the public and private radiotherapy service providers in Victoria. It captures all episodes of radiotherapy that was delivered in Victoria, and it's really for the purpose of health service planning. But there's a whole range of data that's captured in VRMDS. There's patient data, there's institutional data, there are radiotherapy treatment details data, and because the vast amount of data that's actually captured actually offers this opportunity to really utilize it to evaluate the choosing wise recommendation. So firstly, let's look at one of the recommendations, which is short course radiotherapy for breast cancer. Conventionally, after breast conserving surgery, most patients, all patients will need post-operative radiotherapy about 5 to 6 weeks. But then there's, over the last 5-10 years, there's level 1 evidence confirming that shortening the course of radiotherapy to 3 to 4 weeks actually doesn't compromise on outcomes, and in fact, it's logistically a lot more convenient for patients. So when we look at the VRMDS data over a 5-year period, we can see that there's an increasing use of the short-course radiotherapy, the upper level there, you can row. And if we look at the data from 2013 to 2015, the rising trend was observed even before the release of the choosing wise recommendation, and it continued to rise after that. So it's actually questionable whether the change in practice is entirely attributable to the choosing wisely campaign itself, the release of that choosing wisely recommendation, but nonetheless, it's quite reassuring to see that there's a change in practice in line with the best level 1 evidence that's available. So another useful information we get from VRMDS data is institutional variation in practice. So the increasing adoption of evidence-based practice is observed across both public and private institutions, as well as in metropolitan and regional centers. So next we look at the other recommendation, which is not to routinely use extended fractionations for radiotherapy, palliative radiotherapy for bone metastases. And again, there are multiple level 1 evidence showing that shortening the course, offering a short course of radiotherapy, even with a single fraction radiotherapy, actually is not inferior to an extended course of radiotherapy of more than 10 fractions for symptom management for patients with uncomplicated bone mets. And so in the VRMDS data, we can see that only about 10% of patients actually have extended fractionations of radiotherapy, and it dropped quite significantly after the release of the choosing wise recommendation in 2016. So this is one that you may kind of attribute it to the choosing wisely campaign, but it's also important to bear in mind some of the changes in practice that happens around that time. There's increasing use of what we call stereotactic radiotherapy, which is a very focused, high-dose, small field radiotherapy that happens around that time, and that's slightly contributing to the decrease in the extended fractionations for radiotherapy. And we look at change in practice by institutions, again, is consistently, you can see that all institutions are doing less and less of the extended fractionation radiotherapy, but you can see that the private institutions in orange there, there's the most significant drop, and what we believe is most of it is driven by the increasing use of stereotactic radiotherapy in private setting. So the other recommendation is not to routinely use adjuvant whole brain radiotherapy following stereotactic radiosurgery. So this is an area that has been quite rapidly evolving in the last 5 years or so. Probably about 5 years ago, whole brain radiotherapy is still a pretty standard of care for brain metastases, and not many institutions in Victoria actually offer stereotactic radiosurgery. In fact, in Austin, it is only towards the end of 2015 or early 2016 when we start offering stereotactic radiosurgery for brain mets. But nowadays, stereotactic radiosurgery is really the standard of care for patients with limited brain mets, and you tend to want to avoid whole brain radiotherapy given the quality of life and the neurocognitive effects associated with whole brain radiotherapy. So when we look at the VRMDS data, we can see that just purely looking at the number itself, there's increase in use of stereotactic radiosurgery from 2013 to 2017. Just the numbers, about 130 to about 200 patients had stereotactic radiosurgery. But importantly, in relation to the choosing wisely recommendation, which is not to add whole brain radiotherapy to stereotactic radiosurgery, you can see that it's a very rare practice. Up to 2017, there were only 2 patients who actually had whole brain radiotherapy on top of the stereotactic radiosurgery. And we don't even have the number to stratify them by institution type and location. So it's really, this is one of the recommendations whether it's questionable whether it's still applicable as of 2019, given that now radiation oncologists in general has been choosing wisely in that respect. We are not doing this, and it really defeats the purpose having a recommendation telling us not to do something that we are not doing it anymore. So hopefully I've demonstrated to you that administrative data set is quite useful for evaluation of the choosing wisely recommendation. It's a pre-existing data. It captures, specifically from a VRMDS point of view, it captures all the radiotherapy delivered in Victoria, and it reflects a statewide practice. For other specialty, there's Victoria have VMED, VAED, a lot of other administrative data that can be used. But it's also important to note that you can't use administrative data to evaluate all the choosing wisely recommendation. For example, recommendation 2 and 5 that I'll just go through very quickly towards the last 2 slides. And on top of that, some of the administrative data really do not have we like the granularity to evaluate the appropriateness of treatment for individual patients. For example, the longer course of radiotherapy for breast cancer, it may still be required in some patients for clinical reasons or technical reasons. So this work has since been published just last month or so. And just very quickly to run through the other 2 recommendations that we can't really evaluate using the VRMDS data. One of the recommendations is not to initiate treatment for low-risk prostate cancer without discussing active surveillance. While VRMDS data lack the clinical information for us to evaluate the appropriateness of this recommendation, the Prostate Cancer Outcome Registry, which is a registry based at Monash Institute, is a really useful resource for that purpose, and we have just published on that recently as well. And at the moment, we're looking at the Australian-wide adoption of this recommendation using the PCR ANZ data. So the recommendation number 5 is not to use extensive local regional treatment in patients with metastatic disease with limited symptoms. So if someone has metastatic disease, very limited symptoms, don't offer them radiotherapy to the primary itself. Well, firstly, it's not possible for us to identify what's actually minimal symptoms using administrative data set. You can't really kind of tease that out from administrative data set. But I think more importantly is more the fact that there's been quite rapid evolving evidence in radiation oncology, and this recommendation is kind of considered obsolete nowadays. There are a few studies. There's the Stampede study was published last year, which shows that in a patient with low volume metastatic disease, if you treat their primary tumor, which is in this case a prostate, it actually improves survival. Even this year, last month or so, there's a study in JCO which shows that in patients with lung cancer with oligometastatic disease, treating the lung cancer itself actually improves overall survival. So this recommendation is kind of not really in line with the most contemporary level 1 evidence to date. So these are just a quick summary of the 5 recommendations as of 2016. Some of these may need to be revised, but that's something that we are going through the College Faculty of Radiation Oncology Quality Improvement Committee at the moment. Thank you.